Alright, coming back to the second part of the autoimmune topics, we're going to talk about something wrong that happened in the tolerance, and also I'll give out a few examples of autoimmune disease briefly, which those diseases are not usually touched upon much in the regular PT sequences. Okay? So when there is a loss of self-tolerance, what you will observe is some type of a chronic inflammations happening, and also lymphocyte infiltrations into normal and healthy tissues. Now, in order to have inflammations happening and lymphocyte amplifications, we learned that we need CD4 T cell. Now, if CD4 T cell is misbehaving in a way, though, that means they will lead to more inflammations and sustained chronic inflammation. So that is what happened essentially. Some populations of CD4 T cells are essentially breaking the tolerance. Now, there are also endogenous factors that can lead to autoimmune diseases, such as genetic susceptibility, and we're going to talk about in few examples, and also exogenous triggers such as infections and non-infections in nature. And the special CD4 T cell that we are talking about here is the Th17 cells, right? So these Th17 cells are accumulating in affected tissues in some of those autoimmune diseases. Commonly we see in Crohn's disease, rheumatoid arthritis, psoriasis, and allergic asthma here. Okay, now we're going to talk about many of these diseases going to touch upon in greater detail in the PT sequences, and I personally will talk about rheumatoid arthritis and psoriasis with you guys in the next week Jam module, so I will skip it here. Okay. Now, so all these Th17 cells, what happened is that they secrete IL-17 and IL-23 in those affected area when we're talking about joint or under the skins, and these things are pro-inflammatories and also trigger cytokines, and basically leading to further development of T cells differentiations and also recruitment of more immune cells into the area. So the conditions basically getting worse and worse. Now we'll talk about in the Jam module how these inflammatory cytokines or these interleukins are being intercepted by treatments that we have, i.e. antibodies that we have, and to help with some of these conditions, in particular psoriasis and some of the rheumatoid arthritis. Okay. So there is this very long name of autoimmune disease here that I highlighted. In parentheses, or in short form, is APECED, APECED. This is the longest dystrophy that I've ever seen in my life. So I don't want to butcher saying this on this recording. I've tried it many times, trust me, and I'm not able to say it completely without getting a hiccup. Now, this inherited defect basically is lack of this functional ARIE genes. Or what this gene does is that it is a autoimmune regulator that are responsible for transcribing factors responsible for tissue-specific self-peptide in the thymus. So if you are lack of this this transcribing factors, what will lead to basically is unable to participate in negative selections, and ended up these T cells would be specific for tissues that will not be eliminated and entering peripheral circulations, resulting in a large amount of different type of autoimmune diseases. So this particular one gene is very important for inducing the negative selections or negative. Now you don't need to memorize this table. This is FYI, okay? So there's another case is that sometimes the HLA expressions are being introduced onto tissues that are normally do not carry these MHC class 1 and MHC class 2 proteins. Now here is a example here. Now thyroid cells do not normally express HLA class 2 or MHC class 2 molecules, but sometimes when there is a interferon gamma produced during a inflammatory responses, it will increase the expresses of MHC and MHC class 2. In general, in all those target cells, it is purposeful. Okay, those are to increase, different peptides are being presented, increase the density of amount of peptide being presented. All these are useful for normal immune responses. But however, these increased interferon gamma can also induce expressions like such on tissues such as thyroid or pancreatic B cells and astrocytes and other specialized macrophage, and leading to a presenting of a peptide that are indeed a self-peptide, but in this case it's being almost presented as a foreign peptide in a sense, and that lead to autoimmune thyroid diseases. Okay, in this case, if it is presenting some of the thyroid peptide, so it's mistakenly being recognized as foreign. Alright, so there are some clear genetic correlations in factoring into autoimmune diseases here. Now the top panel here shows the frequency of which two siblings share HLA haplotypes in a population as a whole. So the percentage here, the 25%, 50%, 25%, the expected frequency from a simple Mendelian genetics type of a concept. So basically you have one pair, 50% chance of the siblings will share one pair of the HLA, and 25% will share two pairs, and 25% will share nothing here. But however, when there is for example, siblings paired with diabetes, it is the distribution is somewhat skewed. Okay, it looks like that there up to 58% of the siblings are sharing two HLA haplotype here. So it is way more than the natural distributions based on the population. So clearly there is some type of a genetic linkage in terms of this disease. Alright, so looking into the what type of HLA, so in type 1 diabetes, okay, for example, that are insulin dependent diabetes, people have identified populations with HLA DQ2 and DQ8 alone have increased risk for having the type 1 diabetes, and those two being type of HLA being carried together would have a even more risk, synergistic. So each one of add on the risk together. And there is a type of HLA that not being shown here is the DQ6. It's been linked to having resistance for developing type 1 diabetes. Right, so there are also some type of a gender differences between the populations having different type of autoimmune diseases, and that has been linked to the presence or absence of estrogens. So it's been observed that autoimmune disease are more prevalent in women. Okay, for example, in rheumatoid arthritis, there is about a 3-to-1 ratio affecting female versus male here, and also there's seems to be a increased incidence, onset post-menopausal. Now, it may be age-related. Okay, this causality have not been established very clear. In multiple sclerosis, again, 3:1. In systemic lupus erythematosus, or simply called SLE, the ratio is 9:1, usually onset during puberty. So there is a link to increased estrogen productions, right? Estrogen increased in the puberty. So clearly there is a quite significant differences. Now, again, I am going to talk about SLE in your next week's GEM module, so I won't talk about too much here in terms of treatments and things of that nature. And it has been observed that certain type of autoimmune diseases here I listed here, RA, multiple sclerosis, have some improvement during pregnancies here. So could be due to increased progesterone signaling during pregnancy. So it is a somewhat complicated story behind. There is a somewhat complicated story behind this. On the other hand, SLE does not improve during pregnancy. So this figure provides some explanations in terms of the gender gap differences or gender differences in autoimmunity here. Okay, now first we'll ignore this high estrogen and low estrogen here in this graph. We'll just look at focusing on the middle of the circle. Now there is a balance between Th1 versus Th2 signaling here. Now when there is a small amount of antigens being presented, will lead to a relatively low affinity interactions between T cells and antigen presenting cells. That would lead to Th2 type of immunity, okay, which is more of a humoral, okay, antibody, humoral, and usually they are considered as a weaker type of immunity response or autoimmunity response. On the other branch, when there is a large amount of antigens being presented, there will be high affinity interactions between the T cells and the antigen presenting cells, and that would lead to a more severe, more type of immune response that is led by Th1, i.e. the cytotoxic branch of the immune response. And these has been linked to conditions such as the SLE. Okay, SLE we've seen identified the presence of more antibody affecting or attacking different systemic organs. And in MS and RA, we see cytotoxic T cells are attacking the responsible for some of the tissue damages. Now, here comes to the second layer of the story is to, well, let's input the estrogens into the story. When there's estrogens present in adding into the story, actually it will shift more further toward the Th2 helper site, and that actually worsens the SLE conditions. But on the other hand, when there's low estrogen being in the system here, it will worsen the MS and RA conditions there. Okay, now the interesting part is that now you can administer different type of estrogens or different type of blocker, for example, to help with the different conditions. And now here is the conditions where low estrogens will exacerbate more of the MS and RA conditions. During pregnancies, okay, there is an increase in estrogens or and progesterone type of activity. So actually, it will help with the MS and RA conditions during pregnancy for women. Now, and so it will shift. It will gear shifting toward more of a Th2, which is just an antibody in a sense. They're a little bit weaker type of immune response. So, unfortunately, when the pregnancy is over. If the person have MS and RA, the conditions will return back to to the original state because their hormonal level have changed. Now, on the other hand, pregnancy would not help SLE. Okay, so that is in connections with the previous slide there. Now, what can you do to help SLEs? Okay, things like estrogen blockers. Okay, those so-called tamoxifens. Okay, those can help with the SLE conditions there. All right, so we will talk more about treatments later on. Along with the genetics and the gender differences, and there is the environmental triggers. Okay, so now, so in terms of environmental triggering, there basically you can broadly defined into two categories. First one is the non-infectious type of triggering, i.e. physical trauma, chemical or irradiations. Basically, these actions will release something that are previously sequestered or stored or shielded away type of autoantigens. Now here we have a particular conditions. It's called the sympathetic ophthalmia. Okay, sympathetic ophthalmia. And in this conditions, the traumas, okay, to the eye, okay, that is to the eye, okay, some eyelashes, allows the T cells to cross into the anterior chamber of the eye. Okay, this anterior chamber, okay, to the eye, and where this part of the eyes is usually shielded away from the T cell. Remember the actual biological barrier, okay, that are shielding the T cells from reacting. There's another condition, the Goodpasture syndrome. Okay, this is due to a smoker developing some type of lung pathology, and while some non-smoker with the same syndrome do not. Now, this is due to damage to respiratory epithelium resulting from cigarette smoking. Now, we'll talk more about these two conditions in the subsequent slides. Okay, so for sympathetic ophthalmia, what happened here, the diagram demonstrated there first is a trauma to one eye, okay, that resulting in release of sequestered intraocular protein antigens, and these antigens are through being carried to lymph node, okay, and activated T cells in this way. Now, after activations, the T cells would be able to go through the bloodstream. Okay, they will go into the bloodstream and start attacking the antigens in both eyes. So remember, normally this anterior chamber is being shielded away, and these trauma actually are damaging these shielded area. Now this is really related to a conditions or situations where perhaps a person's one eye are being being attacked and leading to a rupture or eyeball rupture. So you need to really respond to it quickly for that conditions, because once that one eyeball are being ruptured, you have these antigen being released, and if you are not taking care of these conditions by either repairing the damage or in some severe cases removing this particular eye, you will start developing or very quickly having immune attack to both eyes. You ended up losing not only one eye, and you will ended up losing both eyes in this case. So that having trauma to one eye definitely need a very rapid response in order to preserve the second eye. And so in some cases, I suspect you would probably need some immunosuppressant drug to suppress some of the activity for a short period of time. Right, so the second condition is this Goodpasture syndrome. Right, so we talked about the environmental factors. There are also some type of a genetic predispositions associated with it, having this HLA-DR W2. Okay, you don't need to memorize this specific terms for anything. Right, so those environmental factors and genetic factors add together will contributing to the developing of this autoimmune disease. So what are the environmental factors? We have smoking, exposure to different types of organic solvent, hydrocarbons. So it could be basically the pollutions from vehicles or from cars, and also infections, cocaine inhalations, and exposure to metal dust. So a lot of those are chemical exposures. These infections will be infectious in nature. All right. So once these triggering factors are involved, there will be autoantibody being generated to start attacking type 4 collagens of the basement membranes, okay? And almost all patients suffer from some kidney inflammation, glomerulonephritis, okay? And about 40% of those will develop pulmonary hemorrhages that, are more correlated with cigarette smoking. Right. The reason of that is the damage. The lung is more damaged because of cigarette smoking. So and the antibody are having more easy access to those basement membranes. So here is just a figure, okay, illustrating these green area here, showing how these antibody are against the glomerular basement membrane. They don't need to know the very nitty-gritty details being listed here. Alright, when you have this syndrome, what kind of symptoms are being presented in general? So there's fatigue, nausea. Those are pretty not specific. Painful urinations, okay, because your kidney is inflamming and also leading to blood in urine. When the lung symptoms occurs in the lung, or damages occur in the lung, you have associated symptoms such as having difficulty breathing and also potentially coughing up some blood. In terms of lab value, okay, these lab values here I bracketed are related to lung functions, and here the lower brackets are related to having seen cells, different type of blood cells in the urine, and actually also decrease kidney functions, increase creatinine, decrease the creatinine clearance. Okay. Now for these treatments, very briefly, okay, corticosteroid basically just a general immunosuppressant, okay, affecting NF-kappa B transcriptions, right? And one of the common immunosuppressants are cyclophosphamide, which is a alkylating agent. Now, I'm not going to go into deep down into the mechanisms in this particular unit. Again, I will talk about it in the Gen module. So you see me how just keep referring there. So that's why part of the reason why this particular topic is slightly difficult for me to isolate it out to deliver to in the immunology portion of the lectures. Okay. Now, this drug will decrease DNA replication and cell proliferation, particularly in those highly, rapidly dividing. We're talking about all those lymphocytes there. And also, you can do some more extreme measures. Okay, you can, because it is an antibody-mediated response, right? Antibody develop attacking type 4 collagens, and you can actually do plasma exchange, okay, to swap out the antibodies in the blood, and to help with the conditions. It's not going to be permanent, okay, just for a little bit in a sense. So here we're focusing on the infectious triggeration, okay, infectious triggers. Now, what happened with infectious triggering is that sometimes there is this peptides being on the bacteria that are somewhat similar, okay, molecular mimicry, so somewhat similar looking in a peptide level, okay. Once you break down the bacteria protein into smaller pieces, sometimes the smaller pieces actually look alike to our endogenous peptides, okay, so the T cell recognized pathogenic peptide also become reactive to homologous, okay, homologous means very similar peptide that is in your body, native peptides, and that has been linked to rheumatic fevers and multiple sclerosis there. Now, this will lead to a widespread of polyclonal T cell activations, and some of the T cells that were originally not reactive will becoming activated, okay, bystander activations, due to a lot of the inflammations that is concurrently happening. So it has been, linked to hygiene theory again. It would appear that some of the, early life, if you have more infections, it may protect against autoimmune dysfunctions because your body will get used to, a low level of infection. So again, that has been linked to, hey, if a person have some type of parasitic infections inside the body, you will be generating, a type of, antibody rather than having, things that are self-reactive. Okay, looking a little bit deeper into one of the conditions, rheumatic fever. So it starts basically with the antibody against the streptococcal cell wall antigens, and which is a normal response, okay, a normal response to a bacterial infections. But however, these recognizing these bacteria peptides somewhat crossed over, okay, cross-reacted with heart tissues and leading to rheumatic fever. So it is unfortunate that how these peptide have some type of a homologous similarity. Alright, here is the graphical breakdown of what is happening. Alright, so here we have the pathogen peptide and self peptide mimicry. So basically they are sharing some type of a similarity, and the conditions where they here described bacteria being processed by macrophage, being presented back out, and somehow this naive T cells are being activated of recognizing that particular peptide, and somehow this peptide are cross-reactive with self peptides, and therefore leading to inflammations that is against things of your own. Right, so the last autoimmune disease we're going to cover here is the Myasthenia Gravis. Okay, Myasthenia Gravis is again an autoantibody mediated autoimmune diseases to nicotinic acetylcholine receptors, okay, nicotinic acetylcholine receptors at the neuromuscular junctions. What happened with this antibody binding, it will decrease muscle sensitivity to neuronal transmission. Basically, you are blocking the receptors, leading to symptoms such as the droopy eyelids, double visions, and progressive skeletal muscle weaknesses. Now, these antibodies may either act as an agonist, okay, in this case, it will lead to a different conditions called a Gravis disease, or antagonist leading to Myasthenia Gravis. So there's a little bit small story about Myasthenia Gravis that I like to share with you all. It's actually a little bit small funny joke that by mistake. So when I was a P1 many years ago, more than a decade ago now, when I was a P1, I was doing IPI and with a in an independent pharmacy down in West Virginia, and that so I have a preceptor. So one day the preceptor told me to look up something about Myasthenia Gravis. Suddenly, okay, out of nowhere, it's like, what is that? Like, as a P1, chances are, unless you know someone with this condition, chances are you've never heard of these conditions. And okay, so I'll look it up. as part of these, required exercise during IPI, right? Perhaps drug information or something. So I looked it up, and then what it is, and potentially treatments for that, and then he told me, my preceptor's daughter at the time, she has this autoimmune diseases. Okay. So I just I take it as informations, and then I after the IPI it's done, end of the day, I went home. I was living with my classmates. I lived with my classmates as roommates, and I shared this little story with him after a day of work, and I was describing this Myasthenia Gravis. Both of my classmates, they never heard of this, and then so it should be having antibody, destroying or binding to your nicotinic, receptors, and then binding to receptors. So I mistakenly said in these conditions there is autoantibodies attacking or binding to the preceptors instead of receptors. I say preceptors. It was a little small joke that I generated among the small group there. So very long dragging story about a just one sentence joke. So anyhow. Alright, so in terms of treatments for Myasthenia Gravis, so you have drugs such as in the class of a cholinesterase inhibitor. So basically you are preventing breakdown of acetylcholine, so increasing acetylcholine levels in these neuromuscular junctions. The idea is to have more acetylcholine available in these junctional gaps, okay, so that it can bind to the acetylcholine nicotinic receptors. They can compete with the autoantibodies, so to alleviate the symptoms that are resulted from these antibodies binding. So that is usually the first line of treatment. Now there are more progressive type of more stronger treatments. Okay, azathioprine. So basically, is an immunosuppressant anti-metabolite, which is a purine analog, and basically you are affecting DNA synthesis during the cell proliferation process, leading to less lymphocyte development, particularly less B cell development. Okay, less B cell, less antibody productions in a way. And B lymphocytes, and that would lead to helping with the conditions. Further, you can do surgicals. You can cut out the entire thymus. That's very radical. It's non-reversible. And lastly, you can also do plasma exchange, okay, isolating the cells, separating the cells and plasmas, basically removing these circulating antibodies in the serums, okay, with fresh plasma without those antibodies. Alright, so that's the end of this autoimmune topic. So I go kind of brief, and also I try to not overlap with information you will receive in another class. Alright, so that's for all here, and we will wrap up with some questions. Okay? Alright, you just hear me talking for another 30 minutes, and it is time for Who Wants to Be the Millionaire again. Alright, so we're getting old on this game. I will skip some of the introduction now, and let's move on to our $400 questions. Alright, it is a recap of the material we just went through. High level of estrogen is bad in which of the following diseases? Multiple sclerosis, SLE, systemic lupus erythematosus, rheumatoid arthritis, and D, sympathetic ophthalmia. Alright, so this should be pretty straightforward. I'll give you 5 seconds to think about it. In which condition high estrogen actually are exacerbating the conditions? Alright, 1, 2, 3, 4, 5. Do you have a final answer? Alright, you probably got it. It's SLE. Alright, in this condition, high estrogen can actually exacerbate the conditions. And one of the treatments would be giving a estrogen blocker for this. Alright, moving on to our $800 question. What receptor is affected in Myasthenia Gravis? Alright, so that is a neuromuscular autoimmune disease we just went through a couple slides ago. And first one, muscarinic receptor, B-cell receptor, C, T-cell receptor, and D, nicotinic receptor. Okay, now this one should be quite straightforward if you are paying attention for the past 30 minutes or so. And I'll give you 5 seconds, okay? 1, 2, 3, 4, 5. Pull down the list, click it. Alright. And it's D, nicotinic receptors. Alright, so we've finished up with the autoimmune topic. In this topic, we went through the molecular mechanisms behind the basis, okay, the etiology of autoimmune disease in general, and we touch upon several common examples, okay, to wrap up this topic. Alright, that's all for today, and I'll see you next time.